Welcome everyone to our Facebook Live. I'm Lisa Paladino for Tie Experts, and I'm very excited tonight to have Dr. Scott Siegel with us for a live interview, and we'll be answering your questions all about tethered oral tissues, tongue tie, tethered oral tissues, tongue tie, lip tie, and buccal ties. I'd love to just tell you a little bit about Dr. Siegel. I'm actually going to read his bio because it's very impressive. So Dr. Scott Siegel, MD, DDS, FACS, FICS, FAAP, lots of initials, is a board-certified dual-degree medical doctor and dentist. He's an oral and maxillofacial surgeon. Dr. Siegel is a fellow of the American College of Surgeons, International College of Surgeons, and American Academy of Pediatrics, and an active member of numerous medical and dental professional organizations. Based in New York City, Dr. Siegel is recognized as a pioneering laser-taught surgeon. During his surgical residency and in private practice, Dr. Siegel was mentored by world-renowned pediatric surgeon and tongue-tie pioneer, Dr. Elizabeth Betty Corielos. Dr. Siegel has been treating TOTS patients for the past 18 years, ranging from infants to adults. Dr. Siegel lectures internationally and conducts clinical research and publishes in various areas related to TOTS, including aerodigestive disorders related to TOTS, such as aerophagia-induced reflux, also known as AIR or AIR. Dr. Siegel is currently working as a clinical investigator in collaboration with the Department of Biomedical Engineering at Columbia University and Tel Aviv University in understanding the kinetics of tongue tie movement in infants, children, and adults with ankyloglossia. So welcome, Scott. That's a lot of impressive information about you. We just know you around here as, you know, my favorite doctor and my favorite dentist, and I'm excited to have you tonight so that we can discuss this important topic and answer people's questions. We've got lots of people tuning in. So welcome.
Thank you, Lisa. It's a privilege and pleasure to be here tonight.
Okay, thank you. So we do know that this is an issue that, you know, you've been working on for way longer than I have. I'll tell everybody a little bit about myself in case they don't know me through my pages and my work. I am a certified nurse midwife and a lactation consultant. I work in Staten Island, New York, which is a borough of New York City for those who don't know. And I'm a midwife, but I got very serious into breastfeeding assistance towards the time when I was in school. You know, I realized that midwifery doesn't teach us that much about breastfeeding. So I started doing my own independent learning and was so taken up by the topic of tongue tie when I realized that there were so many babies that all the tricks I knew weren't helping. You know, so I started doing my own research, and I met you, Scott, through one of those wonderful organizations. There are a couple of organizations on tongue tie now. And learning and reading and going to lots of conferences and realizing that not so many people knew about this. So I've made it my mission, the mission of my practice on the breastfeeding side, to make sure that babies get the support they need, that parents know where to find the information. So the tongue tie course that I've created, you know, talks to all the different aspects of tongue tie. And I do believe that when we talk about tethered oral tissues, or TOTS, which is TOTS, tethered oral tissues, it's often simplified, and it's not often a simple condition or situation. Maybe you want to talk a little bit about that, about how it's not always just a trip to see you.
No, absolutely. You know, I think during this whole journey that we've all been on with treating these babies, infants with these conditions, is understanding that it's a complicated sort of anatomy, physiology, and whatnot. And we've come to realize, and the research is showing, that how interconnected the whole body system is.
Anatomy, physiology
itself, and releasing a tongue tie is not the be all and end all or the silver bullet. A lot of people have other issues going on. They can either have neurologic issues, other anatomic issues, compensations throughout the body, tension, and sometimes torticollis, or what we call pseudo-torticollis, where you have tightness in the neck or tightness on one part of the body. And we often find, just by clipping or snipping or laser cutting, a tie, doesn't always help immediately, doesn't always help at all, and sometimes can make matters worse. So try to figure out, what's going to be what, and then also figuring out the role of lactation support beforehand, body work beforehand, and after any sort of surgical intervention.
Right. Yeah. So we talk about the team, right? I mean, we're lucky to have a great team in our area. I'm not sure that everybody listening may have that great support that we have. And the team is, I believe the IBCLC is a, what I call the team leader. And the reason I feel that way is because we are, as an IBCLC, we see the mom, the baby, and the baby together. So I like to call the diagnosis of TOTS as a, not just form, but function. And what the breastfeeding baby's function is feeding. So if the breastfeeding is evaluated and there's deficiencies there, then that's the function is off with breastfeeding, and things need to be addressed. But as you said, sometimes it's a tightness in the neck, a torticollis, where the baby can't turn their neck completely to one way or the other, or even a plagiocephaly, or a positional, the neck to the head isn't right from birth, can cause issues with feeding. And if we jump right to the procedure, it may not help, right? So our team is myself, IBCLC is on the team. Of course, the surgeon, who can be a dentist. Well, maybe you can talk about that, the different types of surgeons, but let me just go on. Then we have body workers. For the older kids, we may often, or sometimes with kids, even babies, we have the speech language pathologists on our team. But so what kind of doctors or medical providers can perform the release?
Any provider or any medical doctor or dentist can perform these procedures. And I think it's important, when you're at least choosing somebody who's going to potentially be doing the procedures, that they have experience doing it, or at least, a real solid understanding of, the anatomy and being part of the team.
Right.
Plus, oftentimes we'll see, little ones going in and out of an office with either an incomplete procedure done, or it's done incorrectly, or there's no follow-up afterwards with it, another appropriate team member. And also making sure that that doctor has the appropriate follow-up as well, and really understanding function. As you said, I think really function is the big driving force that we're really looking at here.
Yeah, exactly. And I know that before I learned a lot about TOTS, I was sending to, or I was referring for evaluation to some providers who didn't realize the totality of what's involved when you release the strain that's holding the tongue in place. Now it's released, and there's adaptive behaviors that have to go on. And I don't think everybody realizes that. So where are doctors learning now? Where?
There's a few places to actually learn. There's a few laser courses, or actually not just laser courses, but tongue tie sort of courses that you can take. And they're usually, you can find them online, or the internet. Conferences are a great starting place. Find a conference, which usually has some sort of integrated sort of approach, basically, where you can have multidisciplinaries all coming together.
Right.
It's a great starting point for a lot of people.
Yeah. I think that's what's so great about the organization that we belong to now. ICAP. If there are any professionals listening, any IBCLCs, any dentists, doctors, body workers who are interested and aren't a part of ICAP, it's such an interdisciplinary training and collaboration that I've never experienced that. Usually conferences and groups to learn are separated in their own silos, and with the way we're learning together, it really does make a difference, I believe.
Right.
Because we work as teams, right? I mean, so
yeah, that's the whole goal at this point, is to really have some sort of team.
Yeah. So I realized we jumped right into things, and there may be people listening that don't even know what tongue tie is. So could you give us what you would consider your definition of TOTS?
Yeah, the basic definition is the term tie is sometimes a misnomer, but we call these little restrictions or frenulum in the mouth, where you have the little attachment from the lip to the gums or to the teeth area. Underneath the tongue is that little string, if you want to call it that, that holds the tongue to the floor of the mouth. And then sometimes you can have little webs or tethers in the cheeks or other parts of the mouth. Mm-hmm. Now, in an instance, in a oversimplified sort of definition, is that these frenulums are either too short or too tight and restrictive. And basically what happens is they can impact the function of the tongue, the lips, the mouth, and the whole oral cavity as it relates in the infants to feeding. In older children, it can cause other issues up through adulthood.
So what are the other issues? I get asked this all the time, and I know what bothers me is I feel like we're trying to predict the future, but you never know. So I refer things backwards. So I know speech, right? So I know that some kids with speech problems are found to have a tongue tie, but that doesn't mean that every child with a tongue tie is going to have a speech problem, right? So how do you counsel parents about that?
Well, a lot of times if they're coming in and they're already having, let's say, a functional problem with breastfeeding, oftentimes what we see during growth and development is at each point of growth and development, what we have found and the research has shown is that these children do not outgrow these ties, if you want to call them. They grow with them. They need to compensate for them. We found that they don't really stretch. Research has shown is that maybe they stretch up to about 3%, and it has to deal with what we call the collagen types in those areas. But often we'll find, in a sequential manner, you might start with a breastfeeding issue. Many times you'll see a child with a tie go from a breastfeeding issue into when they transition on to solid foods. Some have a tough time handling solid food.
I've even seen like bottle feeding. Mom goes back to work and they're trying to get the baby to take a bottle while she's at work, and baby's not having it, So yeah, that's common.
Yeah, it's not uncommon, and you can have different types of feeding issues that way.
So,
moving beyond that, then we talk about speech issues that we often see in the form of articulation disorders, when they struggle getting tongue position up to the roof of the mouth or behind the teeth for certain letters. Same with the lips. Sometimes they'll have difficulty moving the lips, and it has to do with mechanics. It has to do with growth and development, and these things also affect how the face grows and develops, the jaws, and all of these restrictions. The research keeps coming out almost on a daily basis, looking at the impacts of these soft tissue restrictions on the growth and development of the jaws, the airway,
right,
other things. And more recently, some bigger papers have come out of Stanford University, out of UCLA, looking at children and adults with sleep apnea or sleep disordered breathing, and found that restrictions like a tongue tie potentially makes that more of a risk for them looking down the pike. Now, one of the difficult things we have is to predict who's going to have that. So we're working on that right now as far as research to see, is it a real marker for that? Who will develop those issues? Is, when you look at risks and benefits, is it worth the risk of just releasing the tie? Potentially won't.
Right, right. Yeah. It really is one of those difficult topics because even sometimes breastfeeding may be going well, but there is a significant restriction, you know, especially in a mom who has nursed before and has a great milk supply, you know. So it's a complicated issue and nobody wants to do anything to their baby if they don't have to. And, you know, as a midwife, when I first heard about the procedure, I was anti-procedure. You know, I was like, no, we don't need, babies are perfect. They don't need any help. But it does seem that in the last few years, this is increasing exponentially. It's almost to the point where I don't see too many babies that are having difficulty feeding that don't have a form of oral restriction. So do you have a lot of babies that come to your office that you feel like you don't need to do the procedure on them?
Well, you know, it's an interesting thing. I get asked that a lot, and I get that asked by even parents that come in. One of the things I always stress to them is I have a biased population that I see, because the majority of them are coming in because of a functional problem.
Right.
Either been screened by, you know, pediatrician, IBCLC, and found to have something going on. There are ones that come in just for me to kind of, you know, rule out or really say, we're not sure. And then there are certainly ones that we do turn away. I had one today that had more of a neck body issues. And I figured, let's do all of the other things first.
Right.
And potentially reevaluate. But we do see.
So as part of my tongue tie series, we're going to have Facebook Lives with different body workers, but I just want to touch on that a little bit. What we mean by body worker is somebody who works on the soft tissue, like a chiropractor. We're very lucky to have a great craniosacral therapist who's a physical therapist on our team, massage therapists, these people that can help release that tension so that the baby can open up or position themselves in a better way for breastfeeding and use all their muscles efficiently. One of the things that I know, we've had a couple of, you know, shared patients where the baby seemed to have been done, had the procedure to release the tie too soon and without the body work, and everything's still tight then. Or the baby seems to have reattachment, which that's one of the things we're going to talk about. You know, what are the possible complications? And one of them I know is reattachment, and that seems to happen more often in the babies who haven't had body work, because I feel like they don't get a full release without having some relaxation in the head and neck and chin and all the areas there, so that they can't even, if they can't open their mouth, it doesn't matter if that tissue is free under the tongue or under the lip, they can't move from here, nothing's going to happen. Right. So what are the other possible complications? Because I know that parents worry about this. And I was just looking, I just took a little glance at Facebook. We got lots of people watching and it's so exciting. You know, give us thumbs up and please post your questions so we know that we're hitting all the topics that you want us to cover. We only have a short time with Dr. Siegel, and I want to take advantage of it. So post your questions. But yeah, so what are possible complications?
So when you talk about, you know, general complications of this sort of surgery, we usually list them, and it's seen on a consent form, like pain, bleeding, swelling, infection, potential injury to other structures like salivary glands and nerves. In my own experience in the past, this is going on my 19th year of doing babies at this point, I've not had any of those as a complication. The biggest risk, if you wanted to call it a risk, or the issue that we deal with, is the reattachment, as we call it, where heal back together, or there's scar tissue formation, the limitation of movement. Now, we found that, like you said, is when all of these babies, we find that has reduced in the amount of, I'd say, risk rates, with the amount of either body work that's done beforehand, any potential oral work, like you said, to kind of loosen up compensations. And that really has brought our reattachment rates next to, we're tracking about 1% to 2% of it. Very low.
Yeah.
There's really no major complications that we have seen. It's reported in the literature. I've not seen any of those my own practice.
Right. I think, I mean, not a complication, but a concern is the discomfort. And the discomfort is real for a baby. I mean, you know, we know because grown-ups who have had the procedure can attest to the pain,
Right.
at least for the first few days. So making sure that the baby's comfortable enough to feed is a big part of it. And there's different, you know, I always tell people we can't give medical advice on Facebook, but we can say to ask the provider that you're working with and ask the IBCLC that you're working with to suggest ways to relieve the discomfort. So we won't go too much into that here. So the other, there were a couple of questions that came in. Let me just look at this to make sure. One of the questions that came in today is, what if we can't find help where we live?
Excuse me.
What if someone's in a place where there's nobody that understands the issue, or the pediatrician that's taking care of the family says, no, everything's good, you know, just keep going, and the pain with breastfeeding is normal, or it'll go away, or so what can we tell parents who may be listening?
That's one of those things. And when I talk to other professionals that may be training and whatnot, or even how to listen to a mother or family, is typically most of the times if a mom's instincts are kicking in saying something's not right, something not right.
Right.
And oftentimes what we have found in the medical community, and potentially, you know, dental, whatnot, is that most physicians and dentists really aren't educated or versed on tongue tie evaluation or tethered oral tissue evaluation. It's really not part of the medical or dental education.
Right.
And for the most part, a lot of times they get dismissed. Sometimes pediatricians, depending on the pediatrician you're working with, will only look at certain parameters when you're coming in. It's like, well, you know, pain is normal. It's not normal for breastfeeding.
Right.
Maybe they'll say, oh, your baby's gaining weight, so from visit A to visit B, they're looking at certain parameters, but then many people aren't looking at the big picture of how is that baby feeding? How is it, you know, working for the mom and the baby and the family? Looking at that whole big picture. And I know you can give a lot more information about that.
Yeah. Well, I feel so strongly about that it shouldn't hurt that I wrote a book, right? So my book is It Shouldn't Hurt to Nurse Your Baby, because I had so many moms coming to me saying, it did hurt, but wasn't it supposed to? You know, and no, it shouldn't. So yeah, my book, I'm going to post the link in the chat here if anybody's interested in looking at my book. Okay, so the thing that I like to communicate to moms is, you know, we've very often say, you know, don't learn from Dr. Google, don't be on Facebook, whatever, but we know that parents find support with each other and do learn about things, and there are places to find practitioners who do understand the issue. So, you know, if anybody was ever in an area where they couldn't find anybody, they could message me, or ICAP is a great organization. I believe there's a list there of different people around the world, or at least ability for those of us who are participating to be able to refer people. So if say there's somebody in Oklahoma, I don't know if there's anybody in Oklahoma who's on Facebook, they can message one of us and we can find out who's in their area and give them the information for that, right? So, and I'd say not to give up, you know, don't just take no for an answer, you know. And I've seen women who are amazing heroes trying to find the right answers, right? I mean, I'm sure you've had people travel from pretty far away to see you also, right?
Sure.
Yeah. So that's really, really cool. Okay, we have some questions coming in. So this is a good one. Okay, so somebody asked, Rachel asked, do lip ties always come with tongue ties? What a great question. Thank you, Rachel.
Yeah, I mean, in my experience, they usually run together. Now, having a hard statistic, we don't have that objective data, but you know, it seems like genetically speaking, they typically run together most of the times. Maybe that's in the 90%, 95%, maybe close to 100%, because many times we'll see you lift up the lip, and if there is a true restriction, they often have a tongue tie or restriction associated with that.
Yeah, that's my experience as well. I also think that the lip is discovered easier because it's easier to see by a layperson, right? You know, one of the things that I just, you know, before we were talking about looking on Facebook and talking with people on Facebook and getting support on Facebook, but I think it's important not to get a diagnosis on Facebook, because even though it may look like the baby has a tie, you know, as you said before, it's about the function. So it may look tied, but if there are other things going on that are preventing the baby from feeding well, just fixing the lip and the tongue tie doesn't necessarily make breastfeeding better. Like, for example, if mom doesn't have a good milk supply, then it doesn't matter if we release the tongue. So it's really important to be working with an IBCLC. And for those who don't know, an IBCLC is an International Board Certified Lactation Consultant, which is the gold standard in lactation. I'm going to sound a little bit like commercial, but there's a lot of differences there's a lot of initials that can stand for different kinds of lactation care. And a lactation consultant isn't necessarily an IBCLC. So not to take away from the other breastfeeding help, all levels of breastfeeding help are very important, but a peer counselor is different than an IBCLC as far as what her resources are and what she knows and how she can help. So it's important for all you moms and dads who are listening to realize the difference, and that if you're seeing a breastfeeding counselor who's not helping you and you feel like there's still an issue, go further. The same thing with, you know, like we were saying, if your pediatrician isn't helping you, go further. It's the same on the lactation side, right? Okay, so let me see. There's another question in here. Oh, this is an interesting one from Diana. I'm not sure if this is covered, but I want to ask if you know of any correlation between lip and tongue tie, sacral dimples, and metopic craniocytosis, all midline. My son has had all three, and I'm wondering if it's coincidence or something I should be more concerned about. Thank you. So, want to talk a little bit about midline defects?
And you know, when people talk about tongue ties and other midline defects, there are some correlations that we look at, and some of those were just mentioned. You know, the dimpling, sacral dimples, sometimes even a little blood vessel, sugar vein and whatnot on the nose,
right?
And some other issues. You know, it doesn't necessarily mean that all tongue ties have those other midline issues going on.
Right.
It doesn't mean that they're all bad, but it's just sometimes we see them traveling together from a genetic standpoint.
Yeah. I notice a lot of like stork bites in the back of the neck, but is that related or not? I don't think we really have the research to prove that yet. You know, the issue of, is it a genetic mutation? There is some talk about the MTHFR mutation being associated with midline defects, including tongue tie. And I don't know if it's there yet. You know, I haven't. Have you seen anything recently that I've missed?
No, there's a lot of theories on it at this point, but I don't really put it out there as solid science yet.
Yeah. I think there's a lot more research, as in so many of these topics about tongue and lip and all ties, right? There's so many things that we don't really know yet, but we're learning as we go and collaborating and doing the best we can, one mom, one baby at a time. Okay, so I have another question. Heidi asks, any stretches from a feeding therapy standpoint to help when a release has been performed and the muscle is still not moving correctly? So I think that may tie into, maybe we should pause, step back, and talk a little bit about what the actual procedure is, how you go about that, what to expect that day, and then we'll go into what to do it for aftercare.
Right.
Bear with us, Heidi.
Yeah,
Thank you for the question.
The ideal way or the approach that we would take in the office is that, you know, if the appointment's made, that you've already seen the lactation consultant, potentially you've had whatever other therapies you've needed to get started, and then we come in and, you know, we evaluate, certainly go over the history of what's been going on with function and, you know, on a 24-hour cycle and what's brought you into that point. And really do our examination and a thorough oral examination and look to see where anything is restricted in the mouth. You know, I evaluate the whole body as well, but a lot of times the babies are coming in at this point, for the most part, pretty well worked up. We'll have an idea of what's going on.
So most of the babies that come to you have seen an IBCLC already.
At this point, that's different than years past.
Yeah.
As education has been going on, the majority of them are really coming in with some sort of team. And I think we're a little spoiled because of this location.
Right.
Because of that.
Yeah.
But, you know, in an ideal world, that's how we work. You know, so a lot of times my work at this point as being a detective is really less than it used to be. A lot of the families are coming in pretty well functionally diagnosed at this point.
Right.
Or described anyway. The procedure to do a release itself, which I won't get into too many details, from a surgical perspective is actually a fairly, you know, quick surgical procedure. I don't like to minimize surgery saying it's simple or safe or whatnot, but as far as invasiveness and risks and complications, it's on the lower side. But as you were talking about, the question was about stretching exercises. So even though the procedure is like a 30-second to 45-second procedure to do multiple restrictions, there's a lot of follow-up afterwards doing exercises. Number one, we want to prevent things from healing back together, that reattachment. So there is a set of exercises that we do to just stretch the wound apart. Then there are other exercises which we hand back over to you, the IBCLC, and other therapists involved to work on function and working on the function of the mouth, the neck, the back, the full body. So it's not a simple answer.
Right. I think that I would answer Heidi to say that if there's not improved function, if, you know, I like to always consider, well, what was the issues, what were the concerns before the procedure, and then how are they afterwards? You know, so if it's that the baby, this sounds like it might be an older baby, because feeding therapy, or if it's breastfeeding, just if that's not happening, then go back to the source, you know, so maybe there's some tightness there. So maybe it's body work, maybe it's additional exercise, but I would go back to either the surgeon or the IBCLC or both. And if you're lucky, Heidi, maybe they're a team that'll work together and can see what's up. There are lots of exercises that are very individualized. So there's general exercises that I suggest for almost every baby. But then if that's not enough, or if there's special circumstances, then I would refer out to someone who's a specialist in feeding therapy exercises, right? Like an SLP who specializes in feeding therapy. There's controversy about whether or not myofunctional therapy is actually appropriate for a breastfeeding infant. So we won't get into that controversy, but there are definitely exercises or things that can be done in the mouth that will help one baby more than another, or maybe one baby needs a particular exercise. So it's not a one size fits all, which is why we need the specialized team help, you know, especially as we get to older kids, I think. So about how long do people spend in your office? How, you know, getting back to the procedure day. So the procedure itself.
Yeah, the average length of time in my office is usually about an hour. And that, because the consult time takes a little time, procedure time is fairly negligible. but we spend a lot of time actually, talking to the families beforehand and then dealing with them afterwards, because we don't just, do the procedure and then you're on your way.
Right.
After a procedure is done, we do go into another room, try to latch.
Right.
Want to get your baby back on the breast, at least get some skin to skin going, and soothe the baby, let them settle down. Then we actually come back and review everything that needs to be done at home as far as what we call post-operative care. And that includes stretching exercises, which we show on the actual baby. And we have the family videotape that so they can see exactly what to do. The other thing is to go over pain management techniques and anything else that might be related to the aftercare. And then what happens after they leave, families will usually follow up with me on a weekly basis. Many times they're traveling, so it's difficult to see me on a weekly basis. So what often happens is they'll basically send pictures via text or email to me. So that's the average type of visit that.
And do you feel that, about how many babies that you do see and release ever have to come back for recheck, even if it's not, like a reattachment or whatever? Do people come back, or it's usually just one visit and then they follow up with their IBCLC?
Yeah, they'll usually follow up with who's dealing with the function. And they'll stay in close touch with me during the healing process to monitor the wound healing.
Right.
Monitoring function and seeing what's going on. I'm very fortunate to have, close relationships with a lot of the IBCLCs I work with. And if there's something going on, they usually get in touch with me very quickly.
Right.
I'm not sure about this. I think we might be dealing with reattachment. I think we might be dealing with that. So kind of on an individual basis. But I think, whoever the provider is really needs to be involved in that loop as far as follow-up. And then follow-up is concerned. I mean, it's a very important thing and should be, a concern for families. If you're not given any follow-up, I would ask for, make sure.
Yeah. I'm going to tell a secret that maybe not everybody knows about Dr. Siegel. He gives his cell phone number out to all of his patients. And he does answer and he calls back, and that's very rare to find in today's world, to have the phone number of the surgeon to text. But it's great. Okay, let me see if there's any more questions that came in. This is a great question. Ariana asks, can you recommend any professional resources to share with providers, mainly pediatricians, who are not tie savvy or perhaps dismiss the idea of tongue tie? So I think, like I said, the professional organizations, the other, there have been a couple of resources. There's a new book called Tongue Tie, right, by Dr.
Richard Baxter.
Dr. Baxter, right. And his team wrote chapters, which is wonderful. I also have, My Parents' Guide to TOTS. Doesn't have to just be for parents. It's kind of a cheat sheet for professionals to learn all about tongue tie. I touch generally on a lot of issues in the course. So we're going to be posting that. If it's not already in the chat, it will be the link to the course. There's lots of ways for providers to learn through that course, what to expect, what the symptoms are, what we look for when we're looking for a provider to release the tie, what to expect right after the procedure. I have a handout there for that. When to reach out for help. And that's another question that came in, how after a procedure, what would be warning signs that, immediately after the procedure, what would be warning signs that you would want your clients or your patients to let you know if what happens, what's the danger signs to look for?
Right. I mean, basically in the beginning, there's not too many real dangers, but if a child's not eating, you want to make sure that they are being fed. If they can't latch on the breast at all, and you have to try different ways to feed them. Make sure they
Exactly.
hydrated. I think hydration in the very beginning is one of the biggest things we are always concerned about. Bleeding, I don't see that, but that would be something to be, cause for concern if you had bleeding that was stopping or feeling uncontrollable to the family. That's something they get an immediate time.
Right.
A big question is always fevers. In the first 24 hours, we typically see an elevation in temperature. It's usually less than 100, and up to 101. Sometimes you can see it run, even in an infant. Typically, we don't treat it with anything, and the babies are being hydrated. But those are, I think, some of the biggest things we'll see in the very beginning. I don't know what your experience is, but
that's great. Yeah, I tell parents to let me know if the baby's not eating so that we can talk about ways to eat. The baby's crying too much, what to do about that. Different ways to feed the baby. Sometimes a baby needs to get a bottle, but sometimes a baby won't even take a bottle. So maybe some finger feeding, some syringe feeding. I like to recommend a bath with the baby if mom is up to it, getting in the bathtub with skin to skin, lowering the lights, of course, getting help to get in and out of the tub. But that usually recenters both mom and baby. What I find is a lot of moms are, as you see, really nervous, very anxious about the procedure in that day and having to go through this with the baby. And babies always pick up on our energy. So if mom can get to a centered place and calm down, the baby will do much better. And so the bath, a little bit of lavender oil in the bathtub, mom feels better, baby relaxes, they do skin to skin. And that solves most of the problems that I see the night of the procedure.
Probably the biggest thing that helps, that I find when I get the text or the call that the baby's hysterical.
Yeah.
Once they do that warm bath, skin to skin, Epsom or however else you want to do it, I always get, thank you. It worked like a charm.
Yeah. Yeah. And then the other thing is not to be so worried, not the baby needs to eat, but if the baby missed one feeding, the baby's going to be okay. So calming the baby down is more important than forcing the baby to eat that first feeding. And the baby will do better as they go on. So, most of the time these babies aren't in that, we don't do procedures on babies that are that fragile, that missing one feeding, the baby will be okay. Because I think moms, especially a baby's been feeding every hour, every 2 hours for the first 3 weeks of life and now skips a feeding, it seems like it's dangerous for mom, mom thinks of it that way. But I think those babies, they're resilient, and maybe baby needs just a rest to collect their thoughts and get centered again and learn how to use that tongue all over again. I have another. Well, this is great. Heidi posts, thanks for the answer. I'm lucky enough to be an IBCLC working with Dr. Baxter's patients. It does seem like the later the tie is released, 6 months and longer, the longer it takes to resolve the latch issues, as the muscles have been tethered longer versus 6-week-old. You've encouraged me to connect with some of our local oral feeding specialists. Yes, Heidi, absolutely. I see the same thing. When a baby's used to using their tongue a certain way, it's going to be harder for that baby to make the adjustment. And they're settled into their ways already, right? We see that. Sometimes it's even difficult to get a 6-month-old to nurse in a position they're not used to. So now we're doing something different with their mouth, and they have to learn all over again. And yeah, reach out to oral feeding specialists. Heidi, if you're not on any of the professional pages, there are some great professional pages. You can message me and I'll give you links to sign up. We got some great groups going on Facebook, right? Okay. So we wouldn't have a complete night if we did not talk about your research, Dr. Siegel. So tell us especially about your research about reflux, because I think it's fascinating.
Yeah, I mean, there's stuff about reflux is, I think, research that kind of happened by accident, and something we usually do. And what we found over the years of treating a lot of these babies with breastfeeding problems or even bottle feeding problems, within the first week or two after doing a release, we found that a lot of these babies' reflux symptoms were settling down very quickly. And I talk about reflux symptoms because a lot of these babies were coming in on medications, prescription medications, because they were either in a lot of pain after feeding, either spitting up, or what we call silent reflux sort of symptoms, arching the back and seemingly in a lot of pain. Many times what we were finding, especially when we started adding lips to the whole scene of lip and tongue tie release, is we started seeing reflux rates drop very quickly. And I did some, retrospective or looking back studies, even at, charts and surveys that we had done, and found that, and in my own conservative numbers, more than 50% of these babies that had reflux or diagnosed or being put on reflux medications were being able to be weaned off of them within 1 to 2 weeks.
That's
So we
amazing.
found that there was a correlation to that. And when we were able to publish that, I was able to present it to the American Academy of Pediatrics back in, it was 2015. And it's starting to get some traction. We are starting to see some referrals from pediatricians and some direct from pediatric GI people looking at that. And one of the biggest things we found is that, these medications that are almost knee-jerk response to put a baby on can have some pretty significant side effects. And the side effects can actually, include bone weakening or bone issues. It can also cause potential alteration of what we call the gut flora. And there's some studies that, or some papers that have come out looking at that and making these children potentially more at risk for developing allergies. And there's been correlations to that. So that's where that kind of came into.
And we have so many allergies now, right?
Yeah.
So many kids with allergies.
And that was there was an article in the Journal of the American Medical Association this past summer that came out looking at that and found that they think there's a correlation to the increase in allergy rates to the actual increase in antacid medication rates that have been, so.
It's sad. So we're doing this to babies. First do no harm. What happened to that? Right? Yeah. And then you're doing research currently as well, which is even more exciting.
We're trying to get some objective data on the before and after what we call organization of tongue movements, or of frenotomy or frenectomy or release, and afterwards, and how it impacts breastfeeding. We've been actually able to take ultrasounds of a baby before and after, which is a very non-invasive or minimally invasive approach to imaging.
So it's done actually when the baby's feeding, right?
Right on the breast. We have the baby.
That's so cool.
Do the imaging study, and then we have some people over at Columbia University analyzing the data.
Really smart people, right?
Very smart people. I don't even understand how they do it, but they're mathematical, biomedical engineers, and they're showing objective changes that are positive. Showing that what we do,
right?
Some real meaning to it. There's actually some objective data and science that we can show to other physicians at some point once we get this through publication. We're still collecting data, but it's looking very promising at this point.
It's so exciting because we have to prove what we know in order for other people to believe us, right? Thank you for doing that for all of us. Couple more questions. Carrie asks, sorry I came in on this late. Did you speak about posterior tongue ties? Well, we didn't really talk about the classification at all. So if you want to, they're the tricky ones, right? The posterior ties. The anterior ones are easy.
We always kind of, I guess at some point we can post, pictures of what these look like.
Right.
But we in general categories, we talk about anterior versus posterior. And then we break them down into type 1 through 4 for the most commonly used classification systems, which are Dr. Kotlow's classification system. Betty Carrillos also had a system that's used that way. And the type 1 is what we call the classic tongue tie. It's that little string right at the tip of the tongue that everybody can see across the room. As that little attachment gets further back from the tip, it becomes what we call more posterior. So generally speaking, we say type 1 and 2 are anterior, type 3 and 4 are more posterior. And it really becomes something that's not an easy thing to diagnose. Basically what happens is, I don't want to really start to get into the details of diagnosis because I think it's beyond this, but you really have to kind of know what you're looking at. And I find that most pediatricians, unfortunately, don't know what they're looking at. And they'll say, well, they're fine. They don't have a tongue tie. They can stick their tongue out. Where a child with a posterior tongue tie can actually move the front part of the tongue. They can stick the tongue out, but often they can't elevate it fully.
Yeah.
They get that very good, what we call wave-like motion.
Mm-hmm.
Where they struggle elevating the middle part and the back part of the tongue up to the roof of the mouth, dropping it down to form, you know, an efficient vacuum, if you want to call it that, to bring the nipple deep enough into the mouth.
Yeah.
What will happen is the nipple stays to the front and they channel.
So the basically, you know, like in layman's terms, the posterior tie is not the one that we learn about in mainstream education. We learn about that classic heart-shaped tongue, or the right at the tip of the tongue, and, you know, kids who lisp, you know, really prominent lisp, and posterior is more of a hidden one.
Right.
Yeah. So another really interesting question Rosa asks, is it more typical for premature babies to have ties?
Not necessarily. In my own experience, now these things form in the first trimester, so I don't know if there's any correlation between the, you know, number of ties and, you know, premature babies or whatnot. Because
I think that maybe in the premature babies, if it's been a NICU baby, they typically have more feeding issues due to the separation from mom, due to not being able to nurse right away, and due to things that, you know, interventions that have been done to them, whether or not they've had oxygen or a feeding tube, or they've been in funny positions. You know, if they've been in the NICU, they haven't been, you know, lots of skin to skin and things like that. So I find more tightness in premature babies, sometimes a little bit of early plagiocephaly that will affect eating. But I see the incidence not to be higher. It wouldn't make sense for it to be higher. Just that maybe that those babies have higher rates of feeding difficulties if they didn't get started right away with feeding. Do you think that's?
Yeah, I think along those lines for sure.
Yeah. Okay. Let me just go through these and make sure I didn't miss any of the questions. Patricia says, "Hi, Lisa and Dr. Siegel. I'm noticing that my baby never sticks his tongue out post-revision. Is this a sign of reattachment?"
No, not from my standpoint, not necessarily. No. We don't really look at tongue, you know, sticking the tongue out.
Right.
Anything, unfortunately, that's kind of, you know, I think some people get hung up in that, including pediatricians or other, you know, other healthcare providers.
Okay, if you hear my dog in the background, excuse her. Go away. She's saying time's up, and time is almost up, but let me just make sure that we don't have any other questions coming in. Rachel asks, how long is the recovery process? And, you know, I think it varies depending on the age of the baby. I see babies who are younger recovering faster. Same, right?
And I guess it kind of what you term recovery. When you talk post-op pain, I find the first 6 to 8 hour stretch is their worst period of pain. And then they usually kind of sore for the next couple of days. It's about 2 weeks for the wounds to heal.
Right.
So if you look at that, you know, wound recovery, healing. But as far as oral function recovery, you know, it's variable depending on age, other functional problems going on.
I also see, and I've heard other lactation consultants talk about, you know, things seem to be better, and then all of a sudden there'll be a little setback. Usually around 10 days or so, 10 days to 2 weeks, and then things get better again. I like to tell parents or families not to plan anything for the first 3 days after, not to expect anything. Babies may, you know, do absolutely fine, but just in case, because that would be the time to be home and not worry about like parties, or, you know, don't have the baby's christening or baptism celebration the next day, or have a big family party or vacation just for those few days, and just like lay low and have a nursing holiday and hang out and just be together, lots of skin to skin. that's the the most intense recovery period. But then the first 2 weeks can be on and off. And hopefully everybody's following up their IBCLCs and keeping in close contact for any difficulties, because sometimes there'll be slides back that baby may need a little bit of adjustment in, the way you're holding the baby because of the way the baby's feeding now, or how you're sitting, or maybe you need a down regulation of your milk supply, or maybe you need some pumping to increase your milk supply to help the baby, or some finger feeding, or all kinds of things that we can do. Okay, so we're getting near the end. This hour went really quickly. Let me just make sure I'm not missing anything. I don't think so. So I'm gonna do some shameful self-promotion here, and mention again my course, Parents Guide to Tots. And I believe, Dr. Siegel, you've had some parents who've gone through the course and had come to your office?
Yeah, more recently. And what we have found is that they come in so well educated from exactly what we're talking about beforehand, during, and after, that it really, I think it empowers them. The knowledge really is power for these families. And if they can come in knowing so many of the questions, or, either the questions to ask, or they have a lot of the answers already, that they don't have to really get themselves worked up about it. I think it's, priceless.
Yeah, I am, the reason I created the course was just what you said. And it just makes me my heart feel happy to hear you say that, because I feel that most parents deserve, the knowledge that they're not getting from wherever they are, or maybe they are getting some knowledge, but not completely. So, the course is available, and if there's any lactation consultants or dentists who want to preview it, just, message me, and I'll give you a preview to see if you, want to recommend it to your patients and clients. This way we get the word out. And yeah, and you can find Dr. Siegel on Facebook, and he's got a nice website, which we link to in the comments. I want to give a shout out and thank you to my husband, Russ, who's been behind the scenes helping us stay with the questions on Facebook. Thanks, Russ. And thank you so much, Dr. Siegel, for being here tonight and for sharing your knowledge and experience with us, and for all you do for parents and babies. Thank you so much.
Thank you, and for all that you do.
Okay. Good night, everybody.